going to this speaking on fertility preservation. Dr. Kundavi, am I right?
Yes, sir.
And we are happy to have Professor Sanjay Reddy sir to be part of this program, and Dr. Radha, uh, Academic of Par Excellence, she's also part of this program. And with this little introduction, I request Dr. Kalpana to introduce Dr. Kundavi to the audience. Madam, Dr. Kalpana.
Yes, sir.
Good evening, ma'am. It's such a warm evening to welcome such great speakers, ma'am. May I just introduce Dr. Kalpana, ma'am, to introduce our speaker. Kalpana, ma'am, Chairperson of Foxy Infertility Committee, Guru Hospital, ma'am. May I request you to invite our honorable speaker, ma'am.
Before that, it is my honor to welcome you all for this wonderful webinar series, Blossom series, on reproductive medicine. This is initiated on this auspicious full moon day. For this inauguration, we have President of TAPISAR, Dr. Sarath sir, founder president of TAPISAR, Sanjeeva Reddy sir, and also Secretary TAPISAR, Dr. Radha Bembu. Oh, so we have Sampath Kumari ma'am, past vice president, has also joined as a guest for this webinar. This month is endometriosis awareness month. So we have selected a topic, fertility preservation in endometriosis. The speaker is none other than Dr. Kundavi. We have our secretary, Shanta Devi madam, who has also joined in this program to help in these series. So in the future months, we are going to have recent advances and research papers in this Blossom series. So I hope all delegates will be really benefited out of this. We will start with the lamp lighting, Vani. Then I will introduce president, founder president and guest for their blessings. Shall we have Sarath sir profile? So I formally introduce him, even though he is known to TAPISAR, doing dynamic activities as president of TAPISAR. But formally to introduce him, he is senior consultant, reproductive medicine and endoscopic surgeon, Indigo Women Center, Chennai, and he's also attached to Apollo Hospital and senior consultant reproductive medicine and specialist in operative laparoscopy also. He had done fellowship in reproductive medicine at Apollo Hospital, founder and mentor for postdoctoral fellowship program in Apollo Hospital. He had initiated with 2 candidates, and he is a member of various prestigious organizations like Eshrey and ASRM, and he has received the prestigious awards, Best Citizen of India, Outstanding Young Person by JCI, and also Appreciation Award by Indian Academy of Gynecological Endoscopy, IAGE. And also n number of he had been trained
Kalpana,
robotic surgeon.
Kalpana, enough, Kalpana.
Yeah.
Please, no? Yeah.
Yeah,
We'll
requesting you to give your welcome
yeah,
address formally
yeah,
to all the
again,
participants.
sure. No? Yeah. Good evening, everyone. And I'm so thankful to Dr. Kalpana and Madam J. Lakshmi,
Shanta
Madam,
Devi. Shanta Devi.
Dr. Shanta, yeah, for organizing this webinar. And we are thankful to have Professor Sanjay Reddy sir and this one Dr. Radha Vembu from SRMC. And we are going to have an eminent speaker and excellent clinician, Dr. Kundavi, is going to talk to us today about fertility preservation in endometriosis. We are looking, instead of taking too long a time, we are all looking forward to listen to Dr. Kundavi. Dr. Reddy sir, you want to say something?
Yeah, we will formally introduce him.
Introduce.
Shanta, madam, will you introduce Sanjeeva sir and
Kalpana, that's all not necessary. Just we'll start. Okay.
because you are a BC Roy awardee and you have started first MCH in Tamil Nadu or India, I'm not very sure. You
Kalpana, one thing I wanted to say, he is the father of reproductive medicine of Tamil Nadu. Okay, that is one word is enough. No? Instead of all these things, no? Yeah. His
And
He's
as
father.
well
telling
as
indirectly that
as
I'm
well.
old person like that. Tell grandfather like that. That is better, no? Instead of father. Okay, that is enough, Kalpana. Thank you. I'm happy actually for you have started this program from MCOT. We are waiting long time for this thing. I think you started. I hope it will continue. Involve other members also. That's what we want to know. Like not only MCOT Kalpana, other members also should be actively participating in this. Everybody will be happy like that for that. Hope it started. It won't end. It will peak. Okay. All the best for your. Okay.
Efforts.
Thank you so much, sir, for your blessings. Hopefully, this will continue with the New Year research and recent advances in an extensive way. It is my privilege to introduce Sampath Kumari ma'am, who doesn't need any introduction, past Vice President of FOGSI and also President of OGSI, running across India to reach the highest position, and wishing her best wishes for her dreams to come true. And to introduce her, she's a Senate member of MGR University, National
Kalpana, no
Corresponding.
problem.
Yes, ma'am, your blessings for this webinar.
Yes, sir. Thank you, Kalpana. It's really always whatever you start, you will do a wonderful work. And respected Sarath sir, Sanjeev Reddy sir, Radha madam, and Tapi sir, Madurai branch president Dr. Kalpana, and secretary Dr. Chanta. For this opportunity, it's a wonderful program. I know that whatever work you do, you will do it with a full dedicated work. This program will continue. I think you are going to do every month, no?
Yes, ma'am. That's what I'm planning. Probably, if
Yes.
needed, bi-weekly also.
Whatever it is. All the best for and best wishes for this. In this situation, with your permission, I request all of you to vote for me. I am contesting for FOGSI president. The election date is August 1 to August 10. Thank you so much, Kalpana. Best wishes. Thank you. And you have selected a wonderful speaker, Dr. Kundavai. She is will be talking about the fertility preservation. Thank you and all the best. Thank you.
Thank you so
Yes.
much, ma'am. Wishing to see you as president of FOGSI in the near future, and all our wishes will be there to take you to the New Year heights, I think.
Dr. Kalpana, it is all our wishes, no? All our,
Yes.
everyone's
Yes,
wish.
Yes,
No?
yes, yes.
Somebody from Tamil Nadu, no, should represent the
After
army.
Dr.
Yeah, yeah.
Palniyappan,
Thank
long
you, sir.
gap.
Thank you.
Yeah,
Thank
after
you so much.
Palniyappan, madam should reach that position,
Yes,
because
yeah, yes,
we have been
Thank
ignored
you,
for
sir. With all
years.
your supports, we will do it.
Sure,
Thank
ma'am,
you.
sure. Thank you.
Thank you, sir.
Thank you, ma'am. Shall I take the honor of introducing our Radha Vembu ma'am and our Kundali ma'am? As in Radha Vembu ma'am, Professor Head of Reproductive Medicine and Surgery, my old deemed prestigious college, SRMC ma'am. Great wishes ma'am, Joint Secretary of TAPISA, Secretary of TAPISA, past Secretary of TAPISA, and numerous publications and research ma'am. It's my honor and privilege to introduce my own professor to this meeting ma'am. Welcome ma'am.
Thank you very much for giving me this opportunity, Dr. Kalpana and MCOT team.
And I welcome Dr. Kundri ma'am, our speaker today, TAPISA's Vice President-elect, Lead Fertility Consultant at IRM as well, Triple M. And a great honor for me to introduce you, ma'am. I worked under you also in Triple M. Please welcome to this webinar, ma'am.
Radha ma'am, your comments and
Yeah.
you can welcome the speaker.
Yeah. Thank you, Dr. Kalpana. You have selected one of the important topic, and being the theme of the month of March, the endometriosis, fertility preservation is being talked about in many of the forums nowadays. And it's a good topic and given to a good speaker who is well versed with the latest evidences. So welcome Dr. Kundari ma'am for giving her this lecture. I think this is one of the important topics which we are concentrating more and more nowadays in fertility preservation, more so in oncofertility, and of late it is being talked even in endometriosis. So over to you, ma'am. We are waiting to listen to your lecture.
Can you share the slides?
Yes, ma'am.
Can you see my slides?
Yeah, we can see.
Make it full screen.
You can make it slideshow.
Yeah. Can you see it now?
Yeah,
Yeah.
it's seen.
Yeah. Fertility preservation in endometriosis. Preventive, is it a necessity or an overuse necessity? And special thanks for Dr. Kalpana, the Madurai Society, and the TAPISA for giving this opportunity. And wish all the best for Kalpana as well as Sambat Madam for the election. So we know that 1 in 10 women among the reproductive age group is affected by endometriosis, and 176 million women being affected worldwide. Drawing a clear recommendation for fertility preservation in women with endometriosis represents a complete task. And we know that the main reason suggested for the lower IVF success in women with endometriosis are the poor egg quality and reduced ability of the uterine lining to attach the embryo. And we know that the endometriosis women do have a poor oocyte quality, impaired folliculogenesis, altered embryogenesis, and decreased fertilization rates and decreased pregnancy rates as well. And we know that it has got three superficial, deep, and the ovarian endometrioma probably interfering with the pregnancies as well. The fertility preservation counseling for women with endometriosis. This was a survey done in 2022. And they found that endometriosis stage 3 and 4 with multiple surgeries, endometrioma of more than 3 centimeters. They have done an AMH with more than 1 and AFC is less than 5. There's another group. We had an AMH less than 1 and AFC less than 5. If a woman is less than 35 years and is fertility a priority, if she says no, or the other patient who's got 35 years with a partner and she says fertility is a priority, probably do an IVF. Whereas if you have a woman of less than 1 and AFC less than 5, irrespective of the age, the fertility wishes, and a prayer, any surgical surgery, fertility preservation is being advised. Why should we freeze at all? Arguments for fertility preservation is because it has got a direct impact on endometriosis, risk from surgery because surgical treatment would reduce the ovarian reserve. The time is very, very critical because it is crucial to preserve fertility early, particularly because the condition can be progressive and ovarian function can decrease over time. And the suitable candidates are like preservation is strongly recommended for those with bilateral endometriomas, recurrence after surgery, or large endometriomas more than 3 centimeters. Why should we not freeze again? We know that the efficacy of fertility preservation, the number and the quality of oocytes we are going to get from a woman with endometriosis, the impact of surgery on the ovarian reserve, and likelihood of the use of frozen eggs and future infertility, and the validity of fertility preservation in endometriosis was to be addressed. So patients in endometriosis also do have aneuploidy. It was published in 2017, and pregnancy live birth rates are comparable in young fertile women. So they said, why should we freeze? And ovarian endometrioma negatively does not impact the oocyte quality and quantity, but not the pregnancies. So the study in 2017 found that they did not find any difference in live birth women with endometriosis who underwent a donor egg or with their own egg. So this study says that why should we freeze the eggs, because this endometriosis may have a little effect on the egg quality. And the debates of uncertainty is like some argue that fertility preservation may be unnecessary for many young patients with normal ovarian reserve, that intervene proactively can lead to a health-related anxiety and is not guaranteed to result in live birth. And the optimal methods, people have said that oocyte cryopreservation is very common, and the efficacy and safety and the cost effectiveness of the ovarian tissue cryopreservation are still being researched for the endometriosis patient. The fertility preservation of women endometriosis, BJOG 2022, was not favoring fertility preservation because they found that the use of hormonal secondary prevention following a cytoreductive surgery is safe, effective, and recommend the patients for symptomatic ovarian endometriosis. And it is evidently clear that both the clinicians and the regulatory bodies currently lack high quality evidence to endorse routine usage of fertility preservation among with ovarian endometrioma. This preventive intervention may contribute to the health-related anxiety and influence future health decision making without the guarantee of a live birth. So this particular group said they were not favoring fertility preservation. Systematically recommending oocyte banking in women with endometriosis is premature at this point, and they found that the egg banking could be expensive and exposes women some clinical risk. Advocating systematic fertility preservation in unaffected women can cause wastage of resources and exposure of patients to undue risk. So there is a need for the robust cost effectiveness and cost beneficial analysis by various group of people. The real benefit that we have to extrapolate is the absolute difference in terms of live birth between the women who stored the eggs and those who did not. So this was a study by Koba et al., which was not informative on this point. So they found that they may have stored the eggs once, but they were already infertile, but they have to undergo surgery. This is clearly recognized by his studies as well. And this was what people have said. This patient with a suspected endometriosis, you do a laparoscopic confirmation of endometriosis, you find what about the fertility options, surgical gamete cryopreservation, embryo cryopreservation, and ovarian cryopreservation was the various methods of ovarian oocyte cryopreservation as well. So again, you diagnose, you have a clinical decision for endometriosis. And what is it? People who wants to have children and people who current desire for children, it depends upon the younger age group, the medium age group, and advanced age group. And they should attempt of spontaneous or IVF pregnancy. Chance of conception according to the EFI score should be counseled. Patients who are young age, who have a high risk of recurrence, and a median age, still they are fertile, example between 25 to 35. If a woman has got a bilateral endometrioma, unilateral endometrioma after contralateral surgery, unilateral endometrioma after unilateral salping oophorectomy, and deep DIE, deep infiltrating endometriosis, these are the women who have got a high ovarian reserve with the AMH of more than 1 and low ovarian, probably ovarian stimulation cryopreservation of oocytes is being recommended. So we know that patients who consider pregnancy look at the AFC and AMH, look at various things, peritoneal deep and whether they've got an ovarian endometriomas, and discuss the future pregnancy planning. If you have a more than 5 centimeters bilateral and no previous pregnancy, and this is a patient who would consider oocyte freezing. Again, if you have a woman of less than 35, that is younger patient, you have a good ovarian reserve, again, this group have said consider oocyte freezing as well. So do we need to include all patients with the diagnosis of endometriosis in a fertility preservation program is a big question, because you need to have a profound clinical, logistic, and financial effects. So who reads the fertility preservation should be tailored to the patient characters, and this particular side is very, very crucial because age over 35, bilateral endometriomas, that is before surgery, history or the risk of multiple surgery, pre-operative reduced ovarian reserve, ovarian endometrioma and reduced ovarian reserve, previous unilateral surgeries, recurrent endometriomas before surgery, severe endometriosis diagnosis stage 3 and 4, and they're wanting to have baby but they wanted to wait for a longer duration, ovarian endometrioma more than 4 centimeters, Severe cases identified via surgery, low EFI score that is less than 0 to 3, endometriosis stage 3 and 4. These are the patients I think we would, as a clinician, would recommend fertility preservations. But one size does not fit all. So people have said, for instance, you have a woman of 25-year-old without endometriomas, but with diffuse adhesions causing bilateral hydrosalpinx, would require a bilateral salpingectomy, could be an excellent candidate for fertility preservation. Again, on the other side, if you have a multiparous 38-year-old woman with an unilateral small endometriomas, low AMH levels without any adhesions, is likely to have any advantage from egg freezing. So you need to choose your patient for fertility preservation. Somiglina et al. Has categorized endometrioma into 8 distinct clinical scenarios, that is women with bilateral endometriomas, unilateral endometriomas, DIE, previous surgery for unilateral endometrioma with contralateral recurrence, previous surgery for bilateral endometriomas without recurrence, previous surgery for bilateral endometriomas with unilateral, and previous surgery with bilateral recurrence. And there are 3 sets of guidelines where you need that. We have seen given by the Somaglina and the ESHRE and the French guidelines. They do not go together because Somaglina has said that unilateral endometrioma, it is not recommended, whereas previous surgery of unilateral endometrioma plus contralateral recurrence is recommended, whereas ESHRE has said you need to go with individualization of the fertility preservation. Whereas the French guidelines 2021 has recommended if you have a endometrium of more than 3 centimeters, and again what they have said is previous surgeries they've recommended. So the guidelines are not uniform for all patients, and again the clinicians had to individualize for fertility preservation. The recent guidelines from European Society, that is from ESHRE 2022, are even more ambiguous because the French people in 2018 said that patients with endometriomas in case of bilateral or with the history of ovarian surgery or with the deep endometriosis, they have recommended. Whereas the European Society also suggested that extensive ovarian endometriomas, clinicians discuss the pros and cons of fertility preservation. The true benefit of fertility preservation needs to be discussed. So the ESHRE 2020 has said that they do suggest that it is not advisable in case of decreased ovarian reserve. So you have a controversial guidelines between the Somaglina, ESHRE and the French. So you need to have an individualized fertility preservations options. So 2020 ESHRE guidelines have said that when determining the requisite number of oocytes for a fertility preservation, one should consider the live birth rate or the cumulative live birth rate. So to increase the live birth rate, again a catch-22 situation, in a woman with endometriosis will have a reduced AMH, reduced AFC, the multiple cycles may be needed to collect a sufficient number of oocytes even among women with endometriosis. So the authors have suggested 3 aspects before opting for oocyte cryopreservation. Number 1, will a woman ovarian reserve decrease if she undergoes surgery? How many oocytes will be retrieved if the oocyte cryopreservation is performed before surgery? If pre-operative oocyte cryopreservation is performed, is there a possibility of using cryopreserved oocytes in future? Given these considerations, Sumaglina has said that only there are 2 conditions: a woman with bilateral endometriomas, previous surgery for unilateral with contralateral recurrence. Only these 2 conditions he has recommended for fertility preservation. So what is the number of eggs needed when you go for fertility preservation in endometriosis? What they found is, like, if you have a woman of 35 years and younger, minimum of 15 oocytes has been required. Whereas if you have a older woman of 35 years, there is a realistic chance of achieving 1 or more live births only when you have required 20 oocytes. Is it really possible to get these number of oocytes when you go for fertility preservation? Again, number needed to freeze, they talk about 20, you require number of oocytes to freeze for the survival. So, for every 16 women with endometriomas who have to undergo cryopreservation, 1 would be expected to have a child. That is, analysis included only women under 35 years of age. So, need to have a good number of oocytes for them, for us to need for number needed to treat. So what are the various options left for women on things? 1 is number oocyte cryopreservation, most used technique, and embryo cryopreservation if you have a partner, and legal implications for a death or a separation, for a divorce, then you need to be very, very careful because those embryos could not be used. And ovarian cryopreservation requires 2 surgical procedures. damage to the ovarian reserve, potential post-operative development of adhesions is being expected. And what are the pros and the benefits, risk over the fertility preservation? Benefits, you have a high success rate, particularly with the embryos. It avoids a laparoscopic procedure, avoids the risk of damage to the ovarian tissue. The risk involved is a reproductive potential of follicles from endometriosis requires further study. Need to cryopreservate large numbers, which I've said minimum of 50 when you have less than 35, 38, and more than 38, you need to have at least more than 20 eggs to be required, and possibility of impaired oocyte and an embryo quality as well. Coming to the ovarian tissue cryopreservation option for women who require an oophorectomy, who are unable to or willing to undergo ovarian stimulation. And though we talk about an experimental technology, people have done an ovarian tissue cryopreservation for cancers, and the babies are born. But especially in endometriosis, what is the benefit need to be taken, because potential for damage to the viable ovarian things, and risk of anesthesia during laparoscopy, and risk of laparoscopy itself for these women. What are the factors influencing the cost effectiveness? Endometriosis EFI is a score help to predict the future infertility risk, and this particularly can identify women who might benefit from fertility preservation. You have a risk assessment. You have a specific protocols, a progesterone protocol, which is coming up in a very big way, has got a cost effectiveness over the antagon or the long agonist with the endometriosis. Ovarian reserve is high. The cost effect is higher when you do the ovarian cryopreservation in younger women. The intervention of the total cost may vary depending on the chosen method, that is whether it's going to be an oocyte, embryos, or ovarian cryopreservation, which each having its own associated benefits and the cost. Again, a surgical intervention, the potential damage to the ovarian reserve from surgery can make fertility preservation more valuable for women who must undergo such procedures. So what are the challenges? Fertility preservation, the anatomical distortion, the inflammatory ones which could affect the embryo quality and the embryo development, and the reduced ovarian reserve, again leading to a reduced number of viable follicles. The quality gets affected, the iatrogenic injury and hormonal imbalance. All these are challenges in fertility preservation. What about the reproductive outcomes after the oocyte cryopreservation endometriosis? This is a group where they have done that. The elective oocyte cryopreservation for various indications. The estimated live birth rate was about 8.7 who are under 30, and again 2.5 over 41 to 42, and only about 1% with the age of 43 and 44. According to this report, to achieve 70% chance of one live birth, women of age 30 to 34 would need to cryopreserve at least 14 M2 oocytes, whereas above 35 you need to have 15 men, and which above 40 you require 26. So you need to think about the reproductive outcome as well, and the live birth rate, and the pros and cons need to be discussed to the patient as well. And however, for women older than, see, for example, if you have an 35 or younger, the oocyte vitrified was 8.6 in the no surgery group and 5 in the surgery group. The cumulative live birth rate was 72% in the no surgery group compared to 52%. So this was significantly, it was statistically significant. So they found that, so you do an oocyte cryopreservation before the surgery and avoid the surgery before oocyte cryopreservation. Whereas when you have a woman older than 35, the ovarian response, the clinical outcomes are similar whether you have done the surgery or no surgery as well. So what are the justification and indication for oocyte cryopreservation with endometriosis? So you have a few conditions where they remain unmarried or unpartnered. They marry or having a partner and conceive naturally. And they marry or having a partner, but they are not able to conceive naturally or attempt IVF with sufficient high quality oocytes. Or they marry or having a partner but are unable to conceive naturally, and upon attempting IVF, they find that the quantity and the quality of the retrieved oocytes is low. So, however, the use of cryopreserved uses becomes unnecessary in scenarios 1, 2, and 3. So, probably 3 and 4 would be a better option. However, cryopreservation would be essential in the situation 4, where I have said where the numbers and the quality is very, very poor. And these particular group of women may require a multiple ovarian stimulations, and the age and the ovarian reserve are the clinical predictors of success. Younger women had a better when compared to the older women. But what they found is once you receive the oocytes, the comparable IVF would come with adequate oocyte retrieval. If you have adequately had about 15 oocytes, the success rate was much better. So oocyte cryopreservation is a feasible option for endometriosis patients. And we all know that oocyte was cryopreservation was much better when compared to the ovarian tissue cryopreservation. So the importance of fertility preservation before surgery is that before surgery can protect the ovarian reserve from the detrimental effects of surgical intervention. So the benefits of this approach for patients with bilateral endometriomas or a preoperative diminished ovarian reserve. So women with bilateral or a reduced ovarian reserve could offer fertility preservation before surgery. And surgical history, this was found, does the stage of the disease influence the oocyte retrieval? And they found that the surgical history and the disease stage impact the number of retrieved oocytes. Patients with previous ovarian surgery had fewer oocytes, which all of us know, and those without the surgical history. On the other hand, the stage of the disease does not seem to significantly influence the number of cryopreserved oocytes. And previously mentioned, some prospective cohort studies seem to suggest that there is a significant improvement in pregnancy rates in patients with deep infiltrating endometriosis that is surgically treated before the IVF procedures compared with non-operated. This is exactly opposite one in a case of deep-seated endometriosis. So what are the additional consideration of fertility preservation? Embryo cryopreservation is highly effective technique. I think most of us are used when they have a partner. And I think oocyte was preferred in the post-pubertal ones. Ovarian tissue cryopreservation was proven to be effective in cancer patients, which I mentioned earlier, but has been described only in a very few case reports with endometriosis. To conclusion and the recommendations are based on the guidelines released to date. The most important indications for oocyte cryopreservation in women, those with bilateral endometriomas more than 3 centimeters, those who have undergone surgery for unilateral endometrioma and experience whether it is an ipsilateral or a contralateral recurrence, and those with unilateral endometriomas affecting a single ovary. The French clinical practice guidelines specifically recommend oocyte cryopreservation. Bilateral endometriomas larger than 3 centimeters, suggesting that further discussion is warranted regarding the size criteria. I think most of the guidelines say that if you have an endometrioma more than 3 centimeters, go ahead and do the fertility preservation as well. And again, some people have said unilateral 3 centimeters, again presents an ambiguous situation whether with this on one side, whether we should go ahead with fertility preservation. So if an ovarian stimulation is planned for oocyte cryopreservation and the endometrioma is large enough to impede the oocyte, percutaneous drainage of the endometrioma also was considered in certain cases. So again, what I have mentioned earlier, the same thing has been repeated. To what I would suggest is clinicians should inform patients that irrespective of the surgery, natural pregnancy is possible without the use of vitrified oocytes, provided that the ovarian reserve is adequate and that no further infertility factors, that is, you have a good male factor, the tubes patent, and if they have a good AMH, I think you can go ahead with natural pregnancy. Pregnancy through IVF can be achieved without vitrified oocytes if a sufficient number of fresh oocytes can be retrieved. Fertility preservation should ideally be made available to the patient before surgery and should be integrated into the endometriosis management program. The current knowledge gaps is like lack of routine use. Routine fertility preservation is not recommended for all women with endometriosis because you don't have a high quality evidence for the effectiveness and the cost effectiveness. The need for more research has been required. Until these data become available, particularly from RCTs, we need to have the effectiveness of preventive cryopreservation aimed at preserving the future fertility in all women with endometriosis cannot be validated scientifically. So I would say that to freeze or not to freeze, it has to be an individual decision, and the clinicians have got an entire responsibility of counseling these women whether they have to undergo fertility preservation or not. Thank you so much.
Thank you so much, ma'am, for your excellent presentation. And you have covered a whole lot of the pros and cons of fertility preservation in endometriosis. So in our Indian scenario, do you think this will be a feasible option at the present rate, considering the more number of IVF centers coming up? So do you think it will be a suitable option in our scenario?
I think because there are a lot of controversies regarding the number of oocytes, the quality versus the quantity. I think in an Indian scenario, the cost again comes to it, number one. Number two, how many patients are going to come back to us to use the frozen oocytes? I think as a clinician, it's better to counsel a patient depending upon her age, her AMH, And what is her future? Is she going to wait for a longer period? If she's more than 35, and we know her AMH is on the lower side. But again, these people talk about if they are more than 35 to 40, you need these number of oocytes to achieve one live birth rate. So probably a lot of counseling needs to be done. If you ask me, probably it could be included in the management, but not as a compulsory that they should go for fertility preservation.
Because in our
Kundavi,
present scenario, yeah. Yes, sir.
Radha, can I ask one
Yes,
question,
sir.
Amma?
Yes, sir.
Yeah. Kundavi, is there any impact on aneuploidy rate,
So
endometriosis?
they've said
As you
there were few studies by the 2017. They said that and these women had a slightly higher aneuploidy rates when compared to the other women. But we
Okay,
haven't seen
thank you.
much because we know that it could be the endometrial receptivity which gets affected. So probably there's a risk of miscarriage was also no pregnancy, so the risk of early miscarriage was high. And we have found that the ectopic pregnancies were slightly high because they have a distorted anatomies. But aneuploidy we have not seen, but there are few studies which said aneuploidy rates are little on the higher side.
And there are evidences which say that the embryo quality is not affected. So we are going for a frozen embryo transfer. The pregnancy rates are comparable.
Comparable.
So yeah, and the other thing is most of us we are seeing is at the time of surgery we see advanced stage, and after that if we are counseling. So in that situation, post surgery, I think we should give them a minimum period of 3 months for the TMH to improve, and that time whether is it worth counseling them for oocyte cryopreservation, or we are doing an ultrasound and saying that the ovaries are stuck and we suspect maybe stage 3, stage 4. That time, if we stimulate, get the oocytes, and then go for surgery, is it better? Because in our scenario, many of them, they come to us, either they are symptomatic or at the time of surgery, we diagnose them to be having advanced stage.
Exactly. And I think there's another group of patients where I think the recent publication is also come endometriosis PCOS. When women have got more AMH with endometriosis, probably I think they could wait. But whereas AMH on the lower side, where you have to catch them earlier, probably you can have at least 1 or 2 cycles of stimulated cycles as well, minimum of 2 cycles.
And I think
But
one more thing we have to do is counseling is very important, because they should be told that how many number of oocytes have to be retrieved to get one good blast future, because they should not be thinking that we have already frozen and they can delay. That is also one thing, and we need more number of oocytes depending on the age of the patient also. I
Very
think
surprising.
Radha,
counseling is
Look
very
at the
important.
yes, sir.
in Indian scenario, I think cost factor plays an important role. No? So, and with that too, we have stable marriages. No, probably better to go ahead instead of freezing the oocytes or the embryos. Better you encourage the patient to become pregnant at the earliest. No, that is my opinion.
Sir, now we are facing situation where people are coming, even though they have, say, for other indications, we are doing fertility preservation. They say keep some number of oocytes frozen and the embryos separately, because they are not sure of their marriage status.
Contract.
So nowadays it is becoming very difficult, especially with the IT sector people. If we get, say, around 15 oocytes, they say you freeze some oocytes and remaining you do embryos, even the married people. So we
So we are
cannot
getting
say,
westernized.
no, it is very difficult, sir, in these
Okay.
patients. And
Thank
moreover,
you.
we should also consider the lab perspective, how competent they are to freeze the oocytes.
Oocytes.
Embryos, many are competent, but freezing the oocyte and how when they retrieve it back, I mean, they thaw and then after that ICSI, all that has to be taken into consideration before we counsel them. And I think our age-old practice of saying them get married early and finish your family faster is be a better way, rather than counseling for oocyte cryopreservation and subjecting them for repeated surgeries, at least at this stage in our scenario. And
Actually, the counseling for the freeze thaw, survival needs to be done when we are planning for oocyte cryopreservation.
And sometimes we also get some referrals saying that rapidly increasing in size, the suspicion of a malignancy might be there. So in those cases, there will be always a controversy whether we should do oocyte cryopreservation or do surgery, confirm the diagnosis, and then go for oocyte cryopreservation. That is also something which is coming up, especially in a tertiary center. There are so many referrals of oncofertility. So that is also one of the challenges which we face
See, when
in
the
these
people
patients.
talk about recurrence of endometriomas,
Yes.
and we have seen in the last 20 years, there were 2 cases where when the histopathology comes out as mucinous cystadenomas and they are recurrent, they have, and the CA125 is on the higher side when you check for the recurrence, the tumor markers. We have found 2 clear cell carcinomas in those patients. They are not older people also. They are around between 35 to 38 who have come for IVF. So I think that has to be kept in mind as well when you have, when there is a, so you need to have a good sonologist who's going to tell you between the benign versus the malignant potential as well. So when there
I
is
do
a
agree with
recurrence,
you
what I would do, what we were started doing is we also started doing the PET-CT with the tumor markers, because at least we are safer, because when they are, when there is a histopathological report of mucinous cystadenoma being recurrent. Because sometimes when you think it's an endometriosis, and then the histopathology could turn out to be mucinous cystadenomas.
I
Frozen
too had
section
2
may be
questions of,
useful sometimes, no?
yeah.
Yes,
I too
Frozen
had 2
section may be
questions of
useful.
this.
Yes.
Yeah, Kalpana, I too had 2 patients of this one, endometrioid CA, where sonologists play an important role. So they could find the papillary projections into the cyst, and then we have a doubt. But because tumor marker CA125, it will be increased even in endometriosis also, no? But most probably, sonology is most important, I feel, in this particular, if we have doubt about the malignancies in the endometriosis.
Yeah,
some
if we have a
endometrioma do have a varied pictures also, no, sir. So that's what I'm saying, that you need to have a good sonologist who could tell us this is what it is.
Yes.
And one more challenge we face is if we are doing it in an adolescent, and how long we are going to freeze, and what the ART bill says, like up to 10 years and beyond. So those things also should be kept in mind when we are counseling those patients. As of now, I think those who are having a good reserve and who are at risk of having a recurrent endometriosis, so probably in those patients, I think we should take an initiative and counsel them.
Counsel them.
And if they have a partner, definitely we should counsel them for an embryo freezing, and if not, at least a oocyte cryopreservation. Then,
practically before surgery, it is ideal to go
yeah.
for freezing.
Are there any literature, ma'am? How many months you have to wait if they have undergone surgery, and after that you're planning for oocyte cryopreservation to have an optimal outcome?
I've not seen the Madri. I think maximum maybe around 3 months or something following the surgery.
Because for the AMH to recover, it takes 3 months. So, and during that waiting period, are we going to suppress so that the chances of recurrence is not there? Or can just go ahead? That is again a gray
when you
zone.
suppress them
Yeah.
prior to the treatment, those patients might require longer duration of gonadotrophins and higher dose of gonad. So you need to weigh, either this side or that side. I think endometriosis is one way we don't have a proper conclusion of what to do. I think it's like, we know it's a disease of enigma. Again, for us, a decision is also a big challenge.
Yeah, that is true.
Ideally, when we go for embryo freezing before surgery, then we need not bother about AMH reduction.
Yeah, that's true.
So if you have a patient who's married and this, and they say that we want to have a transverse later or something, or they want to plan the pregnancies later after a financial settlement or something, I think those are the women where you can have the embryo freezing. As rightly said, in India, the cost comes a lot for oocyte cryopreservation and other things.
And the number of cycles also have to be taken into consideration, multiple cycles, whether they'll be able to afford when the insurance is not going to cover up.
Even if people say that, progesterone primed could come down the cost, but how much? It is only in few thousands.
Yeah, that is
Instead
true.
of antagon, you're going to use the progesterone. That's all.
Yeah, not much of the benefit actually.
Benefit.
So it's highly impossible to get 15 oocytes at the age
Very
of
unlikely, ma'am. But there is one group, I think recently Mohan Kamath has published,
when
who also look at
with
it, no?
PCO.
PCOs with endometriosis. And if they have a slightly a normal AMH group, maybe that group, younger
Alone will
patient
be.
might benefit of oocyte cryopreservation, because they found that the PCO endometriosis group do have a better pregnancy rates when compared without PCOS. So, and the number of eggs also you get more. So maybe that particular group maybe benefit from the oocyte cryopreservations as well if they are young with bilateral endometriomas. I think 2025 there's a publication on that.
Yeah. Wow. I think we can conclude with this because the discussion went almost for 15 minutes, even though the time of talk is also 15 minutes. Thank you, ma'am. Do we have Shanta Devi, ma'am, to give vote of thanks?
Thank you, Kalpana, for giving this opportunity, and
Yeah, I should thank you because Sarath sir, I wanted to start this program on full moon day. I was stuck with so many programs, and last week only I remembered that it should be
I know.
started. And even yesterday, I had a dilemma whether the program is today or tomorrow. Then my people reminded me it's today. So, in a short notice, I called Kundavi madam to
Yeah.
give a talk, and she gracefully accepted that, and we have initiated that. Hopefully, in the next program, we'll have long lectures and panel discussion, proper program, and it will be a great success, I think.
Thank you, Dr. Kalpana and Madam Shanta, for making it a successful webinar. No? And we look forward to many more webinars
Yes.
in future, Dr.
Yeah.
Kalpana. Best
Yeah.
of luck. No? Thank you. Thank you.
Thank you, Sarath sir, Radha Vembu ma'am, and also Sanjeeva Reddy sir, Sampath Kumari madam, who had blessed this program. So, thank you, Kundavi ma'am, for giving the lecture in a very short notice, and thank you, Dr. Vani, who had
Thank you.
also accepted our invite to be MOC in a very short notice, and she has got a delivery waiting for her, I think, even then. She had joined to complete this program. Thank you so much.
Thank you, ma'am.
Thank you
Actually,
so much.
Shanta madam is stuck in some